Hello and welcome, everyone. I'm going to put out a fire really quick here. Apparently, the stream's URL is not working, which is really interesting and odd. So here, there's people trying to find it, and they can't find it, which is terrible. So I'm going to try and give it to them right on the stream here. Oh, well, that might help. All right. Let's try that. Oh, my goodness. You know, I hate when I'm an idiot. And we all have those moments where we're stupid. But yeah, apparently I turned it to private and not public so that nobody could fucking see it. So that's freaking phenomenal. Yep, there's another person. Yeah, saying that it's private. I know. I just saw it. Try now. Oops. Oopsies. Sorry. This is what happens when... So, yeah, for those that joined, sorry. Thank you guys for joining. I'm sorry that I was a dope. But yeah, apparently I put it in the into YouTube as a private video instead of a public video because I'm an idiot. But we fixed it. Thank you guys for your comments. I quickly saw those. So oops. But good thing I actually checked Facebook literally right as we were going on the air there. So that was swell. This is what happens when you have hunter's brain. I swear it's hunter's brain. You get up in the morning, you're freezing cold, your hypothermic brain, it doesn't work. Then you do normal things all day long, and then you go back out, get more cold, get more hypothermic brain, and then you try and live stream at night. So, yay for me. But yeah, so guys, thank you for joining. We'll be on here, I don't know, a little while. I'm hoping that that Gerard is going to be able to join us. He said that he might be able to join us later on. I know he was driving from family, doing the old Thanksgiving thing. I do thank you guys for joining us on a Thanksgiving weekend. It means a lot, and it's just a fun way to escape family and people that you really don't want to be around, hanging out with me, which I don't know if that's any better. But yeah, so what we're going to be doing is typically I have like a prepared statement or, hey, we're going to go over this presentation that I've done before or, shrank down or whatnot. And honestly, I didn't really want to do that this time. I wanted to kind of just kind of spitball, have fun with you guys and talk, specifically respiratory. So if you do have questions about respiratory, make sure you drop them in the comment box. I can watch them over here. Drop them in the chat, and we could talk all about respiratory. Butch, if you're on, you're not allowed to ask anything about respiratory because you'll probably stump me and make me look bad. So you're not allowed. But for everybody else, other than Butch, or if you're fans of the podcast, the Maha Butchie, go ahead, drop them in the chat, and we'll talk about some respiratory things. But there was a couple things that kind of sparked me wanting to do this respiratory night. And I was in EMT class the other day, and we were talking about different forms of ventilation and stuff like that. And it was the first time, like, I have a refresher in the class that has been doing it for multiple decades, long time. And it was the first time that they had ever, bagged a real other human being under supervision in EMT class. And, and we go, I was sitting there and I was like, yep, this is what we're going to do today. We're going to ventilate people. I want you guys to, see how it is to ventilate a real human being, not just a mannequin. I want you guys to actually sit there and, calculate tidal volume and why it's important. And we actually had, the students work up to, figuring out, okay, they're, 5'5" and their tidal volume is going to be 380. And what bag are we going to use? Are we going to use a adult BVM? Are we going to use a peds BVM? And this is one of the things that, I am a big advocate for is utilizing tidal volume when we're ventilating our patients. Because if we're not ventilating our patients properly and safely, that's the other big thing, is that we have to be doing it safely. Doing the BVM is one of the the scariest, most detrimental things that you could do for your patient, but it's also one of the most life-saving. So, here we are thinking that we're all doing a great thing, and then all of a sudden we have, a pneumo that we've caused because we're sitting there and we're like, just, pushing air into these people. And it's not fair to them, right? It's not fair to them. It's not fair to their lungs. You are supposed to be the smart provider on the scene. And here we are going and doing old medicine, which is, here's an adult BVM, right? This is what we use for adults. But I'm sorry, when you go to the ER or you go to the hospital and you get intubated or, put on any type of vent, you sit there and the respiratory therapist will actually calculate your tidal volume for how much your lungs can actually hold. And if your lungs only hold 400 milliliters, that's what you're going to get ventilated at, because that is the safe, effective tidal volume for your lung volume, or your specific lungs, your patient's lungs. But here we are in EMS going, here's a 1,500 ml adult BVM. And, now we're going, all right, one big squeeze until we can see chest rise. Oh, yeah, we see the chest rise, but we were taught put them a little bit more. So now we're giving like 1,500 mLs, or let's go on the safe side. Let's say you're giving 1,000 mLs and your patient only has a tidal volume of 400. So now you are over expanding their lungs by 600 mLs. That's asinine. That's pneumothorax level. That's barotrauma level. That is, we are doing damage to our patients. Why do you think people are more hypotensive after, cardiac arrest? Not only because they've just been in a cardiac arrest and they should be hypotensive, but we're also pushing so much air into the thorax that we're creating so much added pressure around those lungs that they're going to be hypotensive because you have, more air sitting on vena cavas and aortas and, all of these other major arteries coming back, to and from the pulmonary vasculature and from the body. So it's like, why are we doing this? So one of the big things that I always say is make sure that you're calculating your tidal volume for your patients. And I wasn't prepared to do this because I was kind of just winging it tonight because I felt like it needed to be a little bit more organic here. But here we are. Let's see. Hopefully this works. Will it work? Yay, look at that. I actually made it work. So tidal volume and BVM, right? So we're looking for protective tidal volume. So we go off of ideal body weight. I don't care if you are 800 pounds and 6 feet tall, or you're 100 pounds and 6 feet tall. You will have the same ideal body weight, right? Because ideal body weight is based off of height. Your lung volume is based off of your patient's height. It doesn't matter how big or broad or fat or thin that patient is. So we're going to take this 6 to 8 milliliters per kilo, and then we're going to multiply that by the ideal body weight. Woo! So this is the calculation that you guys need to be doing. So for your male patient, find out how tall they are. That's numero uno. Find out how tall they are. So if I'm, 5'5" or 5'10", right? And so that's 60 inches is 5 feet. So the patient's height above 60. So I'm 5'10", so that would be 10 inches because I'm 10 inches above 60 inches. Multiply that by 2.3. Whatever you get there, you add that to 50, and that's going to be your ideal body weight for me, a male patient that's 5'10". Then we're going to multiply that by 6, and that's going to get your protective tidal volume at the low end. Now, what I like to do is I like to start at the low end, and then if they are not oxygenating well or they need more volume, then you start going up, right? But I like to start at the bottom. So again, this, if I remember correctly, mine is about 340 something, 350 something. So I'm, in the 300s, but yet an adult BVM is 1500 mLs, right? So you're going to squeeze that bag and you're going to give me 5 times the amount of volume that I actually need in my lungs, which is bonkers, right? When we actually think about it. So what we want to do is we want to pick and choose the BVMs that work specifically for our patients. There's nothing in New York State protocol, there's nothing in New York State education that says you cannot take an adult mask, put it on a PEDS BVM, and bag your patient. There's nothing that says that. Now, granted, I don't know. I only know New York State. So, those that are watching from other places, let me know in the chat if there is anything like that, because I would be really intrigued to learn about those restrictions. So again, why aren't we taking the adult mask, putting on a PED BVM, and ventilating your patients? Bingo. There's how to do protective lung volume for BVM, and BVM effectively and safely for all of your, ventilatory patients. It was mind blowing to see, how that worked in that lab. Some people need a little bit more. Some people were just fine. And that was kind of what I wanted people to see was, hey, okay, we figured it out for 6, but they're telling you they need more volume, maybe because they breathe big or whatever. They really fill up their lungs. Then we recalculated it to 7 or 8 and recalculated and redid the math, and then, bagged them effectively afterwards. So yeah, it's just, it's one of those things that I think more EMT providers should know. And I think more, CICs and EMS educators should be doing with their students. Like, it doesn't really make any sense to me why they're not. Other than, hey, we've never done this before, so why should we start doing it now? That's kind of bonkers to me. Going into, other than just ventilatory stuff, going into one of my other big pet peeves, and I get a lot of heat for this, is hypoxic drive, right? So I just did a TikTok on this not too long ago. I've done a YouTube video on it, and one of the crazy things is it's still taught to be scary, which is bonkers to me. So like, you know, when I first took EMT class, you know, 15, almost 16 years ago now, they were like, if you have a COPD patient, and I'm sure you guys hearing this story will be like, yeah, that's exactly what I was taught, because it's true. This is exactly what people do, right? We talk about hypoxic drive in education, and when you're a first brandy dandy new EMT student, you learn if you have a COPD patient, if they breathe based off of hypoxic drive, if you give them oxygen, you're going to abruptly stop the way they breathe and you're going to kill them. And I couldn't tell you how many times that I have gone to COPD patients that have needed oxygen. I've given oxygen. I've taken them to the hospital and they've been completely fine. And I think it really scared a ton of people out of providing good quality care to their patients when they needed to. So, you know, a lot of times I will have to interject and be like, guys, it's not so scary, right? So there is such a thing as a hypoxic drive ventilatory method inside the body, right? What the hypoxic drive theory, though, was based off of one study that was done in 1950 by two doctors, and it doesn't make any sense nowadays. It really doesn't. It's been debunked and rewritten and debunked and rewritten over and over and over, and we still teach it in EMT class, which is crazy to me. So when we look at hypoxic drive, right, we breathe. A normal, healthy human being will breathe based off of high levels of CO2 within the blood. So we look at how much CO2 is in the blood and how much CO2 is within the brain. And we go, okay, there's a high amount of CO2. We need to exhale that. So our body takes in air and exhales the CO2. The oxygen is really great that we're bringing in, but our body really wants to just breathe out the CO2. So that's the way normal people breathe, right? Now let's switch to the COPD. COPDers are classic for air trapping, right? So they keep a lot of the air inside them that they should be breathing out. Right. And this is what's called air trapping within the lungs. And they will sit there and they will continue to hold on to their CO2. So their CO2 builds and builds and builds at a chronic level. They're always at a chronic CO2 high environment. So their brain goes, well, we can't breathe like this because it's chronically high. We don't know when to breathe. So we're going to now breathe when there's low oxygen. Not high CO2, but low oxygen. So that's when the hypoxic drive kicks in and your COPD patients start to breathe with, low oxygen. Now, here comes the fancy dancy EMT provider, and they're like, yeah, I'm gonna, give oxygen to this hypoxic COPD patient. Good. That's exactly what you should be doing. Right? And the myth was if you give high flow oxygen, you're then going to make the body not understand that it needs to breathe at high CO2 or low oxygen because you're giving all this amount of oxygen. So there won't be low oxygen and they will go into spontaneous respiratory arrest. They'll turn into a pumpkin and then they'll die. And maybe if you do high flow oxygen for 3 days straight, that might happen. But doing it for the normal EMT length of a call, 20, 25, 45, maybe an hour, that patient's going to be completely fine. absolutely completely fine. And you know what? If by, the strangeness of the universe, you actually get to a point where they do crap out, what are we going to do? We're going to calculate their tidal volume and we're going to bag them. So who really gives a flying crap if that actually happens, right? We have methods to still breathe for that person and oxygenate them. So, I took a lot of heat from the TikTok community. They actually called me old fashioned, like get with the times. And I was like, really? Like, yeah, it's still a thing, but it's been debunked. So we don't listen to it. If your patient is hypoxic, you give them oxygen. It's just that simple, right? So don't fall into that trap of believing all the hype that hypoxic drive is going to, kill people. If your patient is hypoxic and needs oxygen, you better be giving them oxygen. And that kind of goes hand in hand with oxygenation, right? So like we're kind of, this is how my brain works, guys. It goes from one subject to another, to another, to another, to another. Hopefully it flows, and I try and, poke in some correlation so that everything touches base at least once or twice. But now you can actually see how my mind works. But oxygenation, right? I talked about this in my CME for BVMing people. How do we oxygenate somebody, right? Someone has low O2 saturations. We need to oxygenate them better. We need to raise those oxygen saturations. A lot of people would be like, oh, well, if we're breathing for them, we got to breathe more for them, right? Like we have to increase their respiratory rate. And, yes, but a resounding no, right? There's only two ways to increase oxygenation in a human body. Only two. You increase the amount of oxygen that you're giving. So if they're hypoxic and you're not giving any oxygen, you probably should give them some oxygen, right? If they're hypoxic on 2 liters, you might want to increase that to 6 or 8, 10, right? If they're hypoxic on 10, you might want to give them 12 or 15, right? If they're breathing on a percentage of oxygen, say they're on a vent or BiPAP or maybe a, oh my God, the name, please help me out in the chat. What is the name of the venti tube that you can actually put 20%, 10%? I think it's a venti tube. But you can, choose which percentage of oxygen your trach patients will get. And, so if they're only on, say, 50% oxygen, why don't we bump them up to 100% oxygen, right? And now we're increasing the amount of oxygen that's going into their body for that, for the bloodstream and the hemoglobin to actually utilize within the blood. If that's not working, then the only other way that we can oxygenate our patients properly and effectively is to give them PEEP. And PEEP is positive end expiratory pressure. It's a little valve, okay? Let's see if I can actually, I'm going to raid the Google. See if I can find. Let's see. Open image. That's a terrible image. It makes the point. Let's see. Boom. There it is. So that's what I'm talking about. That is a PEEP valve. Okay. And you can put these on CPAPs. You can put them on BVMs. You can put them on BiPAPs. Now, typically BiPAP is run through a vent. So the vent will have a PEEP function to it. So typically you don't have to add them to BiPAP, but you can. But what you want to do is this is going to increase the pressure within the lungs so that every time that you breathe out, your lungs collapse, right? And there is a natural PEEP. We call it PEEP of 5, right? In looking at the numbers. And there is a little bit of pressure that's left in the lungs that hold the alveoli open at the end of exhalation. Now, what the PEEP valve is going to do is it's going to add some pressure into the lungs so that every time that we breathe out, those lungs stay open a little bit more, right? Increasing the surface area of the alveoli. You increase the surface area of the alveoli, you increase the ability to perform better and easier oxygenation. So again, if we want to increase oxygen saturations, we have to increase oxygen itself or increase PEEP. So make sure that if your agency does not buy BVMs that have a PEEP valve already built into them, make sure that they start, or make sure that they're buying a PEEP valve and then you're adding it to the BVM, afterwards, right before you go and use it. So like those two things. This way, we don't have to sit there and think about, okay, should I be ventilating them 12 times or should I be ventilating them 25 times, right? A lot of people were like, oh, well, if I increase rate, it's going to increase the amount of oxygen that we give. And yes, but it's also doing a lot of other things like increasing their minute volume, right? And we don't want to increase their minute volume unless we absolutely have to for certain patients. So guys, like I said in the beginning, if you do have any respiratory questions, please leave them in the chat. Whew, getting hot. Have to shut off the hat. Yeah, so if you do have any questions about respiratory, any type of specific, why we give certain drugs, how the drugs work, any type of, not just pharmacology, but physiology or, anatomy or any type of thing like that, make sure you're dropping it in the chat. Let me know. I don't mind answering any of your guys' questions. Otherwise, I'm going to sip on my twisted tea here, and I'm going to pick my next thing that I absolutely love to talk about in respiratory, and that is cardiac asthma. So I honestly don't know why. It's so funny when you make YouTube videos, you never assume which ones are going to blow up and be I would think, OPQRST and sample or AVPU or, MI. Those would be the ones that would be yeah, we're going to really, we're going to, be popular and we're going to get tons and tons of views. And then you make a video like cardiac asthma and it blows the hell up and you're just like, why? I don't understand. Why is this blowing up? But one of the things that we kind of have to think about is why everyone always believes cardiac asthma. It's a disease process on its own. What is it, right? And it really isn't, right? It's not a disease process on its own at all. Okay. What it is, though, is a symptom of a greater respiratory problem. And I don't know why people get these confused. So going back to the beginning, right? We have CHF, congestive heart failure. Congestive heart failure, I like to say, is an umbrella term for the 4 types of heart failure. Right? So there's 4 different types of cardiac heart failure. You have systolic, diastolic, left, and right. 2 are causes, 2 are locations. So your causes, that's what actually causes the heart failure. And then your location is where the causes have happened. Okay, if that makes any sense. So with these, you have systolic, which is a squeeze problem. The left ventricle or the right ventricle has lost its ability to squeeze. So ejection fraction, or how much of the 70 mLs of blood that you should be pushing out during every contraction, that goes down, right? Or you have diastolic heart failure, which is a fill problem. There's something happening that does not allow the heart muscle to fill with enough blood itself. The heart muscle itself is fine, but an outside force is acting on that heart muscle, not allowing it to fill. It's getting squeezed from the outside, making it smaller on the inside. So one of those two things is happening, and then where that is happening, whether it be the left side or the right side, that's where we get left and right from. So now let's look at symptoms of left and right sided heart failure, right? So let's take right side heart failure first. Right side heart failure is the right ventricle. If fluid is unable to be ejected from the right ventricle into the pulmonary artery, into the lungs, right? It's then going to back up into the right atrium. It's then going to fill up there, not know where to go because it can only go down in a natural way. It can only go down into the right ventricle. So it's going to get backflowed even further, and it's going to go into the superior and inferior vena cavas, right? The two big main veins that come back into the heart, deliver blood. The superior vena cava delivers it from the shoulders up, and the inferior vena cava, the shoulders down, okay? So all this blood is now returning to the body. So you might see jugular vein distension, you might see peripheral edema, you might see abdominal edema, all around, fluid collecting around the body because all of this extra fluid is going through the superior and inferior vena cavas. Okay, not so life-threatening. Okay, we don't typically see a lot of right-sided heart failure patients with shortness of breath. Okay, if they only have right-sided heart failure. Now we take the left side. The left ventricle fails, whether it can't pump because it's weak and flabby, or it fails because there's a squeeze from the outside. So where does that back up? That goes into the left atrium, which then goes back into where it can only go, which is the pulmonary circulation. So the pulmonary artery, the pulmonary vein. Okay, so the pulmonary vein leads back to the lungs. And now all this extra fluid that should be getting ejected from the left ventricle is now sitting inside of the lungs. And ultimately, you're now drowning your alveoli. Your alveoli are filling with fluid. So you are essentially drowning out all of your alveoli. So your body goes, oh crap, we are getting flooded, right? Think about what they do on ships. You have one compartment that floods. So what does the captain do? He orders the doors to be sealed and locked away from that compartment. So that compartment can flood, who cares, but it's not going to flood the next compartment. Your body does the exact same thing when there's fluid in the lungs, right? It says, okay, we've lost section A7, right? Those alveoli are drowned. We can't do anything about it, so we're going to shut it down. So the bronchioles start to constrict, and this is when you start to get the wheezing. So you've had the rails or the crackles, depending on what lifetime of EMS that you're from, right? You have the fluid within the lungs on your lung sound. So you get that rails, crackle, bubbling sound, right? And now you're getting a wheezing sound. And you're like, why the crap am I getting wheezing? Well, it's because these bronchioles are narrowing, right? They're narrowing down and they're essentially closing. They're going to narrow all the way until they close because the body, the lungs itself, are trying to protect the rest of the healthy lung from not getting invaded by the drowning fluid. So they've done exactly what the ship captain does, and they have cut off those alveoli branches. Okay? Now we're getting wheezing. That wheezing is cardiac asthma. Okay, it's not a disease process on its own. It is a symptom of left-sided heart failure. Okay, so don't think like, oh man, they suddenly have cardiac asthma. Nope, not a thing, right? They had left-sided heart failure, and now their heart failure got really, really bad, and they're drowning, and now their lungs are closing to protect itself. So you, as the EMS provider, should probably do something about it, right? Now, what do we do for wheezing, right? What do most EMS agencies do for wheezing? They give a bronchodilator. What is a bronchodilator going to do to these closed off bronchioles? They're going to open them back up. What do we not want to do? Open them back up, because that's going to let the fluid out to the rest of the lungs. So now you're essentially screwing what the body had just done for you naturally. So you're making your patient worse. You're going to flood your patient. So what do we have to do? There's a specific order of steps that you have to take in a CHF left-sided heart failure patient, right? If they are showing signs of pulmonary edema, you have to put them on CPAP if they are not lethargic and not hypotensive, right? You have to do some form of positive pressure, okay? If they're non-lethargic and not hypotensive, then put them on CPAP, okay? If you have BiPAP, even better, right? If they are lethargic and they're hypotensive, well, then maybe you have to bag them, right? That's manual CPAP. It's manual positive pressure ventilations. So maybe you have to BVM them, or maybe you have to intubate them and then put them on a vent or a BVM or something like that, right? So we have to give them positive pressure. Why are we giving positive pressure? Because it's going to blow air into the lungs. It's going to open those alveoli, and it's going to push that fluid down into the vascular spaces. So it's going to push the fluid out of the alveoli and back into the vasculature where it belongs. So it's going to deflood all of your alveoli. That's a really good thing, right? We want that. So we give the CPAP or positive pressure or BVMs first. That's what we do. We give that first. Then, and only then, if they are still wheezing, then you can give the bronchodilators. I'm good with that. Medicine's good with that, as long as you give them the CPAP or the positive pressure first. Because, again, remember, if you give that bronchodilator first, without the CPAP, you're going to flood them. If the CPAP is working on keeping that fluid at bay and you're pushing it out of the system, and then you open up all those other lungs, all those other lung passageways to get that CPAP in there as well to start pushing out that fluid, you're going to make your patient better. Okay? Now, aggressive, the other pharmacological fix to this is aggressive nitroglycerin. Okay? We want to give aggressive nitroglycerin depending on blood pressure. Different places give different doses depending on different blood pressures. So I'm not going to specifically say, this is the dose for nitro that you guys should be giving. So you give aggressive nitroglycerin typically at an ALS level. I don't know of a BLS agency that does this. So again, follow what you guys know in your local protocols, or just look it up, right? So we want to give the aggressive nitro because it's going to open up those vascular spaces. It's going to vasodilate everything. It's going to make the small pipes bigger. What can we do with bigger pipes? We can fit more fluid in it, right? So this gives a place for the fluid to go. And that's ultimately what we want. We want it out of the lungs and into the vascular spaces. So there's my pet peeve on cardiac asthma. Hopefully, if you were kind of confused on cardiac asthma, you understand a little better now. Just remember, it's a protective mechanism and a symptom of left-sided heart failure. So if you're seeing that, look for other signs of heart failure. Because I guarantee you they're going to be there. You know, peripheral edema, you know, wet lung sounds, anything like that, right? You want to start out and, you know, look for. One of the, let's see, one of the other things that I think we probably should talk about, I'm looking in my one CME presentation here, is this concept here. 30 degrees head elevated. I don't know how many people sit there and go, yeah, I totally know what 30 degrees head elevated is. Most people don't, right? I didn't know about this till a few years ago. You know, everything that we're taught in EMS for specifically for respiratory patients is sit them as high as you can, right? And ultimately, that's what you want to do, right? And we always say, oh, well, it helps them to breathe if they're up, right? They can tripod on the stretcher, they can get into a position of comfort, they can do, you know, they can maneuver their body so they breathe better. Cool. Well, then we looked at, you know, 30 degrees head elevated. And this was something that I learned originally from my wife, who flies with the Air Medical Unit here in New York State. And they did a humongous study, you know, partnering with a bunch of ground EMS and within their company and stuff like that. And they were looking at certain pitches of the stretcher and how it is going to benefit patients. And one of the things that they found was 30 degrees head elevated was the minimum where you should have your respiratory patients, where you should have your head injury patients, and where you should intubate, right? So no more is this lay down your patient into supine position and intubate them on the stretcher, or lay on the nasty floor and intubate them on the floor. Those days are gone. Your patient should be in 30 degrees head elevated. And this is the position that you should have your patient in and about, right? This is about 30 degrees. And this is, you know, the bare bones minimum for what we should be doing with 30 degrees head elevated. Now, there's other things that we can actually look at and get, right? There's devices that we can buy if you're in that position, right? Buy them for your agents, keep them under the bench seat. Or I really like using the first in bag, especially when I'm on scene, right? If I need to intubate a cardiac arrest patient and they have a Lucas on or something like that, I literally take everything out of the first in bag that I need. I lift them up, I slide the bag underneath them, I lean them back over, their head drapes right over the edge of it, not, you know, super hyperextended, but just slightly. And now they are in a perfect 30 degrees head elevated for my next intubation attempt. And I think that is, you know, a really beneficial position to have your patients in. Now, why? Well, there's 3 reasons, right? First off, our chest is really heavy. You know, we utilize all of our energy to breathe. Not all, but a vast majority of our energy goes just into moving the chest up and down and moving air in and out, right? So we want to have the weight off of the top of the chest, right? If we move them up 30 degrees or more, we're moving that weight from here down. That's going to allow the chest to expand easier, right? It's going to allow the lungs to expand easier because you don't have 100 pounds sitting on your chest, right? So that's going to be beneficial. It's easier ventilations. Awesome. Next thing is you're going to increase the amount of lung volume your patient has. So we lose, on average, approximately 50% of our lung volume as soon as we lay in a supine position. So think about that. You have a person with really crappy lungs, horrible lungs, right? maybe they're a cancer patient, maybe they're an end-stage COPD patient, whatever it might be, right? They're having crappy lungs. And now you lay them down to intubate them, or you lay them down, or you don't sit them all the way forward or whatever, and you've just decreased their already shitty lung volume by another 50%. That's not helpful. That's going to be terrible for oxygenation. And then the last thing is if they have anything in their lungs, like fluid or junk, right? Maybe they have pneumonia, or, maybe they're status asthmaticus and they have a lot of mucus production or whatever it might be. If you lay them flat or less than 30 degrees, you're going to move that junk and fluid through the rest of the lungs, decreasing their lung volume, right? Increasing the amount of shitty space in their lungs. Whereas if you sit them at 30 degrees or you sit them higher than 30 degrees, you're moving all of that junk downwards and keeping in a place where you can ventilate and oxygenate most of the lung volume, right? You're creating more lung volume space, which for ventilating patients is better. Just, it is. I alluded to head injury patients. So if you have a patient that has signs of like herniation or significant head injury where you feel like there's a lot of pressure within the skull, you can actually sit them at 30 degrees head elevated, and that is going to help naturally drain some of that fluid out from the skull and into the rest of the body. So it's going to decrease the pressure naturally inside the skull. So again, all of my stroke patients, 30 degrees, all of my significantly, bad head injury patients, 30 degrees, more or less, I don't very rarely transport someone lower than 30 degrees anymore. All right. I must be like rip roaring for you guys because no one's dropped a comment. So hopefully you guys are appreciating what I'm talking about. Again, I'm just kind of bullet pointing all the things that I have conversations like this all the time with new providers about these things, and even current providers, and they're just like, oh my God, I didn't know, or hey, that's really awesome to know, yeah, it's just one of those things that I enjoy to talk about. So I think, holding this stream was fun for me and kind of important for me just to be able to drop a little bit of what I, drop all the time, for people, specifically talking ventilation and respiratory patients. So, again, anything that you guys want to know pharmacological wise or, A&P wise, disease process wise, drop it in the chat. There was an interesting call that was done recently by one of the members of the podcast, and it got me thinking. The utilization of mag on calls, like mag sulfate. You're always taught like, okay, give your oxygen and give your, excuse me guys, that hunting brain's kicking in. You give your oxygen and you give your, albuterol or Atrovent or whatever, bronchodilators and dryers, that your system gives. You give those, and then you give your steroid, and then you're left down to 2, right? At least in our area, you're left down to 2. You're left to mag or you're left to epi. And it's like, okay, which one's worse? Well, epi's totally worse, but, mag's kind of right up there. Like, when do we pull the trigger on mag? When do we pull the trigger on epi? Do we pull it first? Do we wait until all those other pharmacological ways have since passed? It was interesting because, you know, they were talking to me about this call, and they were kind of like, yeah, I don't know if I should have used Epi or I'm sorry, should have used Mag, or not. And they ended up not giving Mag. And, you know, it sounded like the person was really tight, but they didn't have any, like, they said they were short of breath, but there was no visible anything about being short of breath. They said, hey, I'm short of breath. That, like, vital signs, fine. SpO2, fine. End tidal, fine. Labor of breathing, completely normal, right? There was no distress, no whatsoever. But they didn't have any, you know, they barely had lung sounds. And they said, hey, I'm struggling to breathe. They just didn't look it. And, you know, this provider was sitting there like, yeah, you know, I wasn't sure. Like, should I have pulled the trigger? Should I have not have pulled the trigger? And even me, you know, like, they called me just to Monday morning quarterback it, and I don't even know what I would do. And I said that. I was like, I don't know what I would do without looking at and seeing the patient, you know. Would I have tried CPAP? You know, would I have tried PEEP? Would I have tried, you know, Mag at that point if nothing else worked? You know, maybe. I don't know. But, you know, that's an interesting conversation to have. I would love to have that maybe I'll have that conversation in a future podcast episode so that I can get Gerard's opinion. You know, I don't know. The threshold for Mag, at least for me, is like, if they're really, really, really bad and they look really bad, they sound really bad, but they're not like Epi bad, that's when I go to Mag. And I don't even know in this case if I would have made that leap because they didn't look so bad. You know, look is a big thing that we do with all of our patients. We, you know, have that general impression. We have the look test. Oh man, they just failed it miserably. You know, and we take what we see all the time. And we go, yeah, this is what we see. They're really bad. They're pale. They're cyanotic. You know, they look hypoxic. They're struggling to breathe. They're, you know, lethargic. They're, you know, whatever. You put on the monitor. Hey, look, they're tachycardic. Their, you know, respiratory rate is through the roof. Their end tidal is down in the toilet, or up, you know, up in the heavens. Or, you know, their SpO2 is down in the gutter. We look at all these things to form our picture to go, okay, this person is serious, or they're not so serious, or they're somewhere in the middle, right? And so I don't think we should ever knock how much we take in visually for our patients. You know, when you really think about it, I would say 90% of what you do for your patients is based off of what you see and or hear. And that, you know, that's an incredible amount based off of your, you know, your thin assessment that how much comes from those two senses, what you gain from conversation and listening to your patients, or you actually looking at your patient going, yeah, they look like crap, right? I should probably move here. The last thing, because we're winding down on the hour here, the last thing that I want to touch base on really quick is I know this is going to sound crazy, and I know it sounds like a broken record, and you know everyone said this tenfold before, but the reality of BLS before ALS is a real thing. It really is a real thing. I have walked into calls as a paramedic, gone in, seen a really awful respiratory patient, and I'm like, okay, they're really bad. They failed the look test 15 times. Like, they are really, really bad. But you know what I'm going to do? Because I'm a paramedic and I can give drugs. I'm going to go and give them like a steroid and some albuterol. Where then my EMT partner is like, how about you forego that? And how about we bag them? And I'm like, ooh, that's a way better idea than mine, right? EMTs that are watching this, be a prudent watchman of your paramagicians. Because inevitably your paramedic will sit there and go, I can fix this with drugs. And all they need is oxygen, ventilation through BVM, or some other kind of BLS management initially, right? Or maybe throughout the whole call. I don't know, right? Case by case basis. But just know, you have to be the ones to say something, because they're going to have their paramedic brain going, I have a bag of all these drugs and I should probably use it, right? All that BLS stuff goes right out the window. It happens to me. It happened to Gerard. It's happened to all of us, right? Where we go, yeah, I can fix this with drugs. And the EMT's like, or you can fix it not with drugs. And let's try this first. Okay, so, you know, paramedics out there, just be mindful. Start at the beginning, right? BLS is the beginning. Start at the beginning. When you start your ABCs, we don't look and try and fix things with drugs most of the time in the ABCs with drugs, right? We look for oxygen. Yes, oxygen's a drug. Don't nail me on that. Oxygen or ventilation through BVM, CPAP, whatever. Intubation, whatever, right? We don't sit there and break out, well, I'm going to give them their albuterol treatment, and that's going to solve their airway breathing circulation problem. It's not. All right. So let's think more critically and go back to the beginning. So guys, that is, I'm going to wrap it up here. I thank everybody for joining me for this last hour. I apologize for the first few minutes, you guys not being able to use that link. I will remember for next time, that the link should be public, not private. That would help things out. Knucklehead me. But yeah, I just want to take this time. Thank you guys for joining us, joining me, sitting here listening to you know, the non-presentation presentation. Hopefully you got something out of it. If it was just review, that's even better. Just make sure that if you are not a subscriber, hit that big red subscribe button down below. It's incredible that everybody follows this channel and you know, joins me for these events and watches all the stuff, and I am humbled eternally by it. And you can see all the other links on the screen. If you are not a fan of the Facebook, the Instagram, the TikTok, you know, go follow us on all the social media. We are new on Twitter. It's at Medic Materials at Twitter, or on Twitter, I should say. And if you're enjoying, or if you enjoy EMS podcasts, I must say that our podcast is one like none other. It is entertainment fused with education. It is literally your back of the ambulance building conversation laced with education. So it is never a dull moment. There's lots of dark humor. Every EMS provider would probably enjoy it. So make sure to check that out. Medic Materials Podcast on all major platforms, wherever you find your podcast. If you liked what I'm doing here, you want to support us a little bit more, you can become a Patreon subscriber, Patreon/Medic Materials. You can donate $2, $5, or $7, get some awesome perks from that, including a third podcast, some extra educational videos every month. So again, thank you guys for all of your support. I will see you in 2 weeks. I don't honestly, let's see, what is the date in 2 weeks? I'm trying to get these things out every, 2 weeks or so. I'm going on vacation. So it will be, it might not be 2 weeks. It might be 3 weeks, guys. I'm sorry. It'll be the 17th of December. It will be the next one, solely because I'm on vacation and I'm traveling back from the South on the 10th. So the next live stream on this channel will be 10/17 at 8 p.m. Hopefully you guys can join us. Till then, stay strong, stay safe, and donuts, guys. Take care.